Those of us who are statin hesitant are often accused of being science deniers, and if we're not medically trained, we're even considered on the fringe or dangerous. So what do medically trained professionals who are hesitant have to say about this? Let's take a look at that. Stay tuned. Today I'm going to review, in brief, an editorial response by two respected doctors to this accusation about being science deniers. It was made by a cardiologist in an editorial in Medpage Today. One of the two responders is John Abramson, who has authored, among other books, Sickening: How Big Pharma Broke American Health Care and How We Can Repair It. I reviewed that somewhat briefly in another video. The other is Robert N. Kaplan, who has a PhD. He's a distinguished fellow at Purdue University, a professor of medicine at Stanford University. So unlike myself, who has degrees in computer science and not anything medical, these authors have the credentials that should cause medical professionals to sit up and listen. I'm not going to review every bit of this paper, Is Cholesterol Denialism Pseudoscience or Appropriate Medical Care? But I'm going to hit some of the highlights. It is a relatively short editorial, and you really ought to follow the link in the description and read the article in full. So the paper starts out like this, saying, recently a cardiologist published a commentary, and you should probably read that commentary also, in Medpage Today, arguing that physicians and scientists who challenge the clinical benefit of statin medications are pseudoscientists. He claimed that somewhere along the way, cholesterol deniers stopped questioning the scientific evidence and started denying it. The benefit of statin medications, he argued, is settled science. Well, one of the things that's done here is the term cholesterol denier does two things. First, it conflates the idea of statin hesitancy with positions on cholesterol. They are not the same thing. They are related, but they are not the same. And the term denial, it's a soundbite sort of criticism. It's a way to denigrate an opposing position and appealing to emotion. And we hear about deniers all the time, and it's never got a positive connotation. It's always got a negative connotation. So it's an easy way to slam somebody who you disagree with and at least appeal to the emotions of the people who are listening. They go on to say, we agree that the evidence supports the use of statins for secondary prevention in people with established risk factors or with evidence of atherosclerosis. But the benefits, especially for people with low cardiovascular risk, are often modest. This is a classic statin hesitant position. It's the position that I hold. Now, I don't know that these doctors have actually used the term statin hesitant. I should probably try getting that out there. But like most drugs, statins can be useful in the right context. The problem is, of course, they are being used in far too wide of a context as far as I'm concerned. So they go on to say, in a review of the evidence, that among the 18 trials that this U.S. something task force review that evaluated the results of statin therapy for primary prevention of death from any cause, only 2 reported significant benefit. They go on to talk about one of them being very small. One of the things I do want to point out, in all fairness, it's likely that by statistical significance, they were using the 95% confidence interval. That is common in academic research and academic journals. Though there is a lack of significance to that 95% confidence level, I think the data probably indicates that it's more likely than not that some benefit was seen. It just didn't pass that threshold. So we just have to be aware of that. And in fairness, consider that not all results are alike. Something that just barely misses the 95% confidence interval and something that basically says it's totally random, those are different results. Now, when they aggregated all these 18 trials, it still wasn't statistically significant according to this editorial. So that's something for us to be kind of wary of. Then they go on to talk about the Jupiter trial, which was a large trial. It was stopped prematurely when cardiovascular morbidity and mortality amongst patients who received rosuvastatin, that's Crestor, fell below the rate for those assigned to placebo. Well, okay, so there was a difference seen. But the FDA didn't find sufficient evidence to justify an indication that it's preventing cardiovascular death. Neither cardiovascular nor all-cause mortality is included as an indication in the approved package insert for rosuvastatin. The relative risk reduction that was mentioned, I believe in the article that they're responding to, said that it was 20%, and in the Jupiter trial it was 20% over 4 years. The absolute risk reduction was 0.6%. That leads us to ask, are statistical significance and clinical significance the same? Well, they're certainly not. Yes, that 0.6% reduction in mortality was statistically significant, but is it really clinically significant enough to put millions of people on the statin? As a public health matter, perhaps it is. As an individual health matter, well, that's up to the individual, and I certainly wouldn't be taking this particular medication for such a low risk reduction. So then they went on to say, this review concluded only limited evidence showed that primary prevention with statins may be cost effective and improve the patient quality of life. Key point, especially for a lot of my viewers who have had their quality of life destroyed by statins. And further, caution should be taken in prescribing statins for primary prevention among people at low cardiovascular risk. So I think this was an important outcome of the review that they were mentioning in their response. So now let's just look at some of the items that were mentioned in this paper. This isn't the whole paper. Like I said, I'm not reviewing every word in the paper. It would just be me reading to you something that you can read for yourself. So first, in 2013, the American College of Cardiology and the American Heart Association issued new cholesterol guidelines recommending lowering the threshold to initiate statin therapy for primary prevention to anybody with greater than 7.5% 10-year risk. This increased the number of American adults without cardiovascular disease for whom statin therapy is now recommended, and it increased it by 8 million from 26.3 million to 34.5 million. Think about that. Nothing actually changed. All they did was they lowered the threshold. And they just said, let's just give it to more people. That is the approach of increasing the target audience rather than doing more focused prescribing, where we should be decreasing the target audience, being more effective. This paper has reanalyzed the data presented in the Cholesterol Treatment Trial List Collaboration 2012 meta-analysis. Here they say it came to a very different conclusion. It was referring to some other conclusion that somebody had made. For people at low risk, statins did not significantly reduce all-cause mortality, and 140 low-risk people had to be treated with a statin for 5 years to prevent one major cardiovascular event. These are the triple-digit NNTs, numbers needed to treat, that I've been talking about. They later changed their conclusion, by the way, and it's mentioned in this editorial. Investigators in these studies, all but one of which were funded by pharmaceutical makers, according to our review, provided confidential individual-level trial data to this CTT, but they had to agree that the data couldn't be released and would not be used in any publication without the permission of responsible trialists. In practical terms, this means nobody outside the collaborative will be given the opportunity to verify and replicate the results. Well, you think, well, this is an independent group. At least they're being able to see it. Well, one of the leaders in this collaborative was a British doctor, Dr. Rory Collins. We'll talk about him just for a moment here. The BMJ editors noted the absurdity of treating millions of people worldwide with statins while the data underlying these recommendations remained inaccessible for independent analysis. This was in a part of this editorial that was talking about a controversy in which this British doctor, Dr. Collins, attempted to stifle an interpretation of the data in the BMJ and get them to retract a paper which Dr. Abramson had a part in writing, and a few other doctors, I believe Asim Malhotra was one of the doctors involved with that. The controversy is covered in this paper. It deserves a video on its own. If you'd like me to dig deeper into that and tell the whole story of that, just leave me a comment and perhaps I'll be able to put together a video on that. The point is, the BMJ did not retract the article. They had a panel of experts, which included experts in the field, including 2 independent statisticians. They basically decided that there was no reason to withdraw the article. I believe there were some minor edits that had to be done to it. But they go on to say that they have written to the lead investigators of 32 major statin trials and asked them to make their study data available. And 1 year later, only 7 had even bothered to respond. In the way this is worded, that would lead us to believe that the response was no. The others didn't even bother to respond, despite them following up with email and phone calls. 9 years later, the data remains inaccessible. This is the trust us approach. We have the data, we've looked at it, trust us. It shows that statins are effective. You don't need to see the data. Then they go on to say, this is Dr. Abramson and Dr. Kaplan talking again, But even when statins are used for secondary prevention, about 80 people must be treated. So here's the number needed to treat of 80 for 5 years to prevent a death, and about 30 must be treated for 5 years to prevent a heart attack or stroke. One heart attack or stroke. Given these numbers, many people, ourselves included, would choose to take a statin for secondary prevention. Well, here's where I part with them. I don't tell them they're wrong. I mean, they believe that they would take a statin for secondary prevention. If this is the best statins can do, I myself did not find this impressive enough for me to want to take it. And then they go on to talk about primary prevention. For primary prevention, in people with less than 20% 10-year risk, between 100 and 140 people must be treated to prevent a single non-fatal major cardiovascular event. And then they go on to mention something I've mentioned many times before. Those numbers needed to treat. The real ones are probably much higher because the 2013 pooled cohort equations used a calculated 10-year risk erroneously, I might even say purposely, inflate cardiovascular risk estimates, potentially leading to inappropriate statin eligibility for about 17.3 million Americans. By overestimating the risk, they're putting more people than can reasonably benefit onto the statin therapy. So here's their final paragraph. In conclusion, there are two problems with the statin denialism argument. In other words, the argument being put forth by the cardiologist that they were responding to. And that is, peer reviewers, guideline writers, independent analysts have been denied access to the data. This isn't science because the data has been hidden from them. They're not denying the evidence. They just say we need access to it to determine if the science is settled. Calling it into debate rarely serves the advancement of knowledge. Trust me, it's not a valid argument in science. And that's what the pro-statin side is actually saying. Trust us. We've seen the data. We're not going to show it to you. We're going to show you our analysis of the data. You have to accept that. Then they go on to say the age of medical paternalism is, or should be, it's not, but it should be, coming to an end. Shared medical decision-making requires disclosures about the absolute risk reduction and all the other statistical data in a way that's going to be meaningful to the patient. Shared decision-making also means addressing patient concerns by offering alternative treatments such as lifestyle changes rather than the standard approach of trying to convince the patient that their concerns are unfounded. For example, I'm not able to exercise as well when I'm on statins. One approach to address this is for the doctor to convince you it's not the statins that's causing it. That's the wrong approach. Another approach was used on me by one of the doctors, and that was, you're probably exercising too hard now. You have to back off on your exercise. Well, that's not a good answer either. You're giving me this medicine that's supposed to be helping me, and it's hurting my ability to exercise, and you're telling me, well, just exercise less? That's not a good answer. And then finally, the good answer would be say, oh, well, if this is causing that kind of effect on you, what else can we do? Maybe we should look at your lifestyle changes and see if that improves the quality of your lipid panel. That's another problem. They're not looking at the quality of the lipid panels, they're only looking at the quantities on the lipid panels. Finally, they say, importantly, the preferences of those who choose to reject statin therapy must be respected. That's most of my viewers. Doctors who engage in high-quality, informed, shared decision-making are delivering optimal patient care, not harmful pseudoscience. So this means no firing of patients because they refuse statins, no guilt trips laid on them, no dismissing their concerns by saying statins don't cause that. No quiet firing by not providing them any care, but doesn't actively drop them from their patient roles. So those are all important attitudinal things that I think our doctors must follow if they're going to embrace shared decision making. So for my closing thoughts, I'm going to tell us a story. It's one you're familiar with, probably heard of it. It's The Emperor's New Clothes. Now, we all know the story, though unless we've read it, we might not know the details. The story can be traced back centuries, but the version most well known in our culture is the Hans Christian Andersen version from the 19th century. In the story, some con men pretending to be weavers go to the emperor, who's had a reputation for vanity and loving clothes, and tell him that they can weave him the finest cloths to make clothes from with a special property that fools and those not suited for their position cannot see them. The emperor hires them and he sends his advisors to go watch their work. And the emperor's advisors and all the people who look at the so-called clothes, they recognize that they can't see the clothes, but rather than understand that the weavers were con men, they assume that the fault was themselves. In other words, they believe the weavers and they're just like, oh, I must be a fool or I'm not qualified to be in my position. And of course, the emperor's advisors, they don't want to admit that. So all of them pretend that they can see the clothes because they can't admit to their peers or to the emperor that I'm either a fool or I'm not qualified to be your advisor. In the end, the emperor dons his new clothes, which don't exist, and he goes on a parade. And all the people, they admire the clothes. They can't see them, and they know they can't see them. They don't want to admit to their neighbor that they're a fool. A child finally speaks up and shouts out that the emperor has no clothes on. And all the people realized at that point that the child was right. The emperor continued on his parade. He suspected that the child was right also, but he had to keep up the pretenses, so he just kept on going. And that's kind of how the story ends. To me, not a very satisfying end, but that's the way it ended. I think the statin issue is kind of analogous to this, but it's slightly different. I think the statin advocates have actually convinced themselves they can really see the clothes. So it's not a matter of they're looking at the clothes and they're not there and they're pretending that they are. I think they've actually convinced themselves that they can see the clothes. Whereas in the original story, they knew they couldn't, but they couldn't admit it. So when we shout that the emperor has no clothes, they're incapable of dropping their illusions. So they resort to name-calling, cholesterol deniers, and their trust us attitudes. And I don't think I need to tell you who in the modern medical world the conman weavers represent. Big pharma. So who is denying science? Is it those of us who question the received wisdom, or is it those who insist that it's all settled? I guess you can answer that. So that's what I have on this topic. If you appreciate this content, please like, share, subscribe, and comment on this topics or others you'd like me to cover. And if you haven't seen this video, I recommend you take a look at it now. Thanks for listening.